I'm going to reintroduce Dr. Karin Walsh. Thank you.
All right, are you guys sick of me yet? So now you just get my name. You don't need to know anything else about me. This is a fun and interesting talk for me to give to you guys. And I've been really thinking about clinical trials targeting cognition for a while. And I think we talked about earlier that I chair the neurocognitive committee for the RAINS group. So, and the whole point of the RAINS group that Scott and others have developed is to really try to target endpoints for these clinical trials, right? But in the midst of that, I think what I realize is that we really don't have cognition as a primary focus for drug discovery and clinical trials. I'm going to go over what we've done to date that's been published and a couple new trials that are coming up. And again, I think for me it highlights there's a lot of work that we can do to make this more in the forefront as a real target for drug development in NF1. So you don't really need the clinical trials definition too much, but I'll just go over that really quickly, but also the importance of clinical trials for cognition in NF1, a summary of the trials to date, and then we'll talk about the future directions and upcoming trials, and then some resources for you guys for information about clinical trials. I think that Trace Ann, by the way, did print out copies of my earlier talk and this one at the front desk, so you can get a hard copy, but I'm also happy to email so we can figure that out if you guys want copies of the slides. So as you've heard already, I mean, a clinical trial study involves research with human volunteers, right? So participants, we call them, that's intended to add to medical knowledge. And there's really two main types, essentially, of clinical studies: clinical trials or intervention studies, and observational studies. I think Nikki's slide had more breakdown of that, which is, I'm only going to really focus on the intervention components of these studies for this talk. There's obvious importance in NF1. Up to 80% of children have some disruption in cognition and learning, as we talked about earlier. These can have a real significant negative impact on daily functioning in many areas of life. And now that we've spent a number of years really identifying where the problems are for most of these kids and how they're impacting things, now the shift has gone to what can we do about them? Are there places where we can develop interventions, whether it's a drug trial or a behavioral intervention trial? So let me clarify, this is published studies, so this doesn't mean that there's only been 5 studies ever, but these are the published studies that have been done to date targeting cognition and learning in NF1. All 5 of the studies that have been published so far have been drug studies. So there's one that used methylphenidate, a stimulant medication for ADHD, and the 4 other trials have been done with statins, so lovastatin and simvastatin, and some of you may have participated on some of these trials. All 5 of these trials have targeted primarily memory and attention, or some combination of those, which obviously we know are pretty significant areas of dysfunction often in children with NF1 and can be very impairing functionally. And the results of these have been mixed. The methylphenidate study was a positive study, and they showed an increase in attention after treatment, both on ratings by the parents as well as on their performance-based measures, so in the lab, in the office, testing of attention that was done. And then the studies with the statins have been a bit more mixed, and I think it's a little much to get into now, but some of that had a bit to do with methodology and how we're looking at the data, which is again back to the importance of this RAINS kind of initiative, is to standardize how we're going to do these studies and do them better, because there are some issues with the methodology in some of these that I think limited what we could tell that had happened or not. But there's some mixed results here. And the STARS study, by the way, is the one that Michael was just talking about that's not published yet. So that's also a statin drug trial, and we'll see what the results of that are. There's also 2 studies that I'm aware of, and there probably are more, but these are the couple that I'm aware of that are not published and they're in process, or data has been collected, or they're in the process of being published. So there's a Cogmed trial, which is that computerized intervention that I talked about earlier that uses the robot, right? So in the home, this is a colleague of mine at Children's National that's running this. So you're at home, you have a 25 trial session, you do this on a computer, your son or daughter does this on a computer in their home. Nikki's also doing trials with Cogmed, so there's a lot of people kind of interested in this because it works well. You know, you don't have to come into the clinic to do the trial and to do the intervention, and there's online coaching. So as you're working through this, you know, you have a coach that can see all your data and see how you're progressing through the intervention and then give you tips on, you know, do this a little bit earlier in the day or break this up into separate sessions. And so the idea, again, is building on these working memory skills and improving them through this intervention and through practice. And then the coach really guides you so it maximizes the intervention. Again, I've seen this available clinically as well, like in private practices, but I think it gets a bit costly that way. And then there's also been a reading intervention trial that's not published, so I can't talk a whole lot about it, but I was fortunate enough to review it that has some promising results about specific approaches to reading intervention in kids with NF1. So look for that. In terms of future directions, I think we have a lot of work to do, and it's an exciting time to me. You know, as many of the speakers have talked about, we get a lot of our information from the mouse models, right? So they put these mice into little milky pools of water, and they have to swim around and find the little platform, and it's akin to sort of this visual learning idea. You know, do you kind of learn where that platform is, and when we put you back in there, can you find it the next time? And the mice that have NF have a hard time with that. So we know that kind of visual spatial learning is a problem. And then much of the research and the drug trials in the mice have targeted that as an outcome. So, you know, again, that translates maybe a little bit to humans, but we know humans are a lot more complex than that, so sometimes that translation doesn't quite carry through. And I think we can do a lot to improve that in many ways, both having mouse researchers and human researchers talk more to each other so we can figure these out, but also you know, develop different ways of measuring behaviors in humans and in mice where that translates better. And then I think really working hard to increase the importance of cognitive function as a target for drug discovery, because again, this is relatively new and there has not been a lot done. I mean, when you look at the 5 trials, we've got, you know, the stimulant drug trial and then 4 statin trials, and that's it. I'm going to tell you about 2 new trials that are upcoming and either enrolling now or getting ready to, so that we can look at some new strategies. And then I think refining our knowledge about which of the cognitive difficulties have a significant impact on daily functioning, right? So in my office, I can identify a number of different cognitive or learning problems. That doesn't mean they all impact someone's daily life. So I think understanding that is just that next part of the translation into really helping kids with NF do better, have less impact from their learning difficulties. So a couple trials that are upcoming. This one happens to be mine that I'm really excited about, and we've just started enrolling. We have a number of collaborators, and I'm sort of looking forward to getting more kids enrolled in this to see how this comes along. But we are looking at, what we did is take advantage of these MEC trials that Michael was just speaking about. And there's some evidence in the mouse models that suggest that those MEC inhibitors may have a positive impact on learning. We have no idea if that's going to be the case in humans, but we're curious. So since we are enrolling kids for treatment of plexiforms, and adults, by the way, kids and adults, for the treatment of the plexiforms, I thought, let me get in there and test their cognition in the midst of all that while I had an opportunity. So this is sort of a protocol that's attached to that main trial for the plexiforms. And we have Nikki's group at Boston that's participating, the group at the NCI, including Stacy, that are participating, and then Michael's group at CHOP will be participating. So it's very exciting. As Michael mentioned, the RAS pathway is overactive in NF, and I won't go into any more than that. I was glad he summarized that so we could just move along. But we do know that that pathway is important. Besides the tumor growth aspect of it, it is important in learning and memory and does have something to do with the learning and memory deficits in NF1. We don't fully understand that yet, but this is what we're trying to figure out as well. So there's both aspects of taking in new information and storing it, but also then when you need it, going and finding it and retrieving it. Those are disrupted by the disruptions in this pathway. And then manipulating that pathway has improved learning in mouse models. So again, it makes sense for us to then ask the question, does manipulating that pathway in humans also improve or impact learning? So the aims of that MEX trial that we're engaging in is to really examine changes in visual learning and working memory. So we test kids before they start the drug. We test them again at 12 weeks and again at 24 weeks. And we want to see change over time. We want to look at how learning and cognition, whether it stays the same, whether it improves. And there's also a chance that it doesn't improve and maybe even gets worse. We don't know the answer. We are hopeful and we think that it would improve things. But, again, this is a very early study, so kind of any of those things could happen. We're also going to secondarily look at attention and processing speed, those executive functions that we talked about. And then we're enrolling patients from any of the MEC trials. So as Michael said, there's sort of a number of different drugs that are being used that target that MEC pathway, and we're enrolling people on any of those. So we may need to look at the different drugs as well and see if there's some difference between them. I'm using a computerized battery of tests for this, which is we're all targeting like new and efficient and sensitive ways of measuring outcomes. So again, back to that RAINS work that we're doing. And so we're using a battery of cognitive tests called Cogstate, and it's all computerized. We can do it in about 20 minutes, which if you've ever had a neuropsychological evaluation or your child, you know that's sort of an all-day affair. And we can't afford to do that in a clinical trial. So we have to find other ways to get really important information relatively quickly that we know is sensitive and has the ability to answer our questions. So we're using that strategy, which is also exciting because we've seen some promising things. The Cogmed studies have been using that approach as well to measuring outcomes. And then we also use a parent questionnaire to, again, get a sense of what are you seeing in the home setting or the school setting over that period of time, because those are important to have together. The other trial that's upcoming at our site, and there's I realized I forgot to fill in the rest of the participating sites, but I'll let you know who those are. Again, back to my executive dysfunction. So this was just approved, and we haven't started enrolling anything yet, but there's a multimodal intervention trial for cognitive deficits in NF1, and we're looking basically at a combination of Cogmed and a stimulant drug, methylphenidate. Okay, so this is coming out of our group at Children's. Nikki's group at Boston is also participating with this. The group in Australia with Kathy North is participating, and the Children's Hospital of LA. So we have 4 sites for that as well. So this will also be an interesting and exciting study, I think. We know about ADHD and how common it is in NF, so this made sense as a target in terms of an intervention trial. But we also know those executive function, behavioral regulation kinds of things can also get in the way. So the idea is whether, we know from at least that one study, methylphenidate can have a positive impact on attention and some aspects of executive function. We know that Cogmed, from our preliminary studies, has some promise, and now we're wondering if those two together really kind of just are that great combination, right, that enhances all of that and makes it even better and has a better chance to improve these functions than either one alone. One of the other points of this study outside of the cognitive part is really just to see what dose of methylphenidate may be most appropriate for NF1, because I think we know that sometimes our kids with NF1 can be a little bit more sensitive to dose. So part of this is just about figuring out the optimal dose of that drug in the NF1 population specifically. And then also just to follow through with how well do we do with this home-based kind of intervention approach. I will tell you that my colleague Christy will tell you that adolescent boys are not a good population for this intervention. She's done this with many kids, both NF, but a lot of our oncology survivors as well. And she says, everybody does great, but those adolescent boys, they're not doing the sessions. And I think what happens is this does not at all look like the video games that they're used to. It's completely boring when it comes down to it. So they're just not, it's not holding their interest enough to engage them. So there may be certain groups and age groups that this is better for than others. And again, I think learning that is important because then we know where this intervention might have the most promise. So there's 2 phases to this study. Everybody gets treated on the stimulant medication first for 9 weeks. They get evaluated before they start. They get treated for 9 weeks and get evaluated after. And then they go into being randomized into the internet or the online cognitive training phase. So then that's a place where we either put you on what's called a therapeutic Cogmed, or the sort of non-therapeutic, which is akin to the placebo that Nikki was talking about earlier, where you're doing the task, but it actually doesn't get any harder, so it's not meant to improve your skill, it's just meant to keep you engaged. So then we can compare, because again, we don't know, if the intervention itself is going to make a difference, or whether it's just being engaged with somebody, this coach, that's making a difference. So you have to really have that kind of placebo arm in there, or that non-therapeutic piece, to fully answer that question. And then they do that for 9 weeks and then reevaluate it again. And then, of course, we're going to look over time. What happens to these outcomes? What happens to attention? What happens to working memory over the course of this trial? And then do we see improvement? And if so, was it just with the methylphenidate? Was it with the combination of the two? What exactly happened? And that will help, again, answer us in terms of then our clinical care, right? So the whole idea of this is that we then can, as clinicians, be sitting down and talking to you about, well, we've learned that Cogmed works, but not for your kiddo because he's a 15-year-old boy, so let's think about another strategy. Or, that we've learned that these MEK inhibitors have some value. And that's going to be interesting because I think the MEK inhibitors, can have some side effects, and I think one of the things I always think of is I'm not sure if those will be tolerable when cognition's the primary target, right? As Nikki was saying, you may tolerate more side effects if you're treating a tumor that nothing else has worked for. You may not tolerate that same level of side effects if the target is to help your learning. So it will be interesting to learn from you guys, where is that line and what do we need to work with? So I wanted to close just by saying, as the other speakers have, that clinical trials are and really will remain important in identifying viable treatment options for individuals with NF1. And that the identification of these treatments have really the potential to impact kids significantly and their families and adults in positive ways. So it's encouraging. I think we're all excited about the trials that we do and look forward to finding the things that will work so we can share that with you. And I really encourage you, as again, both speakers have already, is to learn more about clinical trials, be educated, and know what to ask, know what they're all about and what their utility is, so that you can make the best decision for you and your family. And so there's a number, and these are printed out also out front, even just this one sheet, with some really good websites that have some very nice educational materials on clinical trials and what it means to be involved and how we utilize that data. So I kind of went fast earlier, but my email is here. A couple people have asked me for cards, and I ran out. So, but please feel free to write my email down and get in touch with me. I'm happy to field any questions, to help you find resources. Whatever I can do to help is certainly, I'm happy to do that. Do you want me to take any questions, Stacy, or did I? Do we have a mic? Thanks, Trace-Ann. Oops. Okay.
General question about testing Neuropsych. My son is 12 now, had a Neuropsych eval at 5. Nothing really came of it other than some sensory issues. There was a question of ADD. My doctor said every 5-year-old boy has ADD, and it was true. He does okay in school, a little lack of function. We see some spatial stuff. I guess we're just wondering now, do we redo a neuropsych eval to see if there's, I'm listening to executive function, and I'm seeing, well, that's maybe a check mark, that's maybe a check mark kind of thing. Would you recommend something like that?
Yeah, if he hasn't been evaluated since 5, I think absolutely, and you said he's 12 now?
He is.
Yeah, I think that's a great time to take a look at things again. And you remember what I said earlier, too, that these evaluations are really snapshots in time. Well, he's developed a whole lot since 5, I bet,
yes,
in very good ways, as well as maybe these challenges may be manifesting in different ways now. And it can be really helpful to figure out where his strengths and weaknesses are. And then, again, in that context of, what, 7th grade or whatever he's in, 6th or 7th grade, what do we need to do to support him now? Because, again, at 5, he probably didn't need a whole lot, even though that you might have identified that attention was a little bit problematic. So I think it could be very valuable for you.
Thank you.
I'm slightly biased, of course, but. Any other questions?
The drug that you were speaking of regarding the ADHD for the neurofibroma,
The
NF1.
methylphenidate or?
Yeah, I can't pronounce it, but
Yeah.
that's the one. The stimulant.
Yes.
Would that be something, once it's approved, that would be for children with ADHD in general?
So that's already approved. It's been approved for a long time. It
Oh.
was just, that trial was to determine whether that also worked in kids with NF and ADHD.
Oh, okay.
But
I
yes,
missed that part.
it and many other stimulant medications and non-stimulant medications are available and approved for treatment of ADHD. And yes.
Oh, okay. It's another line for.
I don't like to say that because people still have a negative reaction to the word Ritalin, but it's okay. It is Ritalin, though.
Well, it is.
See how I secretly sneak it in there so you don't know I'm talking about Ritalin? No, I'm just kidding.
My other question would be, what would be the difference between a child with NF having ADHD or a child that has ADHD but doesn't have NF?
That's a great
One.
question. I
was
think,
curious.
and this sort of goes back to what I was saying a little bit earlier too, that, and the question the gentleman had here about the, the etiology or the source of the problem. Is it NF or is it typical aging or is it something else?
Right.
And the reality of it is the interventions, I'm going to probably tell you the same thing I would if a kid came into my office without NF and had ADHD. The same things work.
Right.
And again, there's many books and intervention strategies for home. There's many resources. If you have a child with NF and ADHD, just look up the ADHD resources because they're relevant. It's not so specific to NF. Now, there might be additional layers or additional issues that are going along with the ADHD in a child with NF that have to be considered because those things happen together, right? I mean, somebody was asking me a little bit before about anxiety and ADHD and, how does that play out? And that certainly can each complicates the other. And so then we have to be more thoughtful and creative. But again, the NF almost isn't that important to me because it wouldn't matter what kid was in my office and what their background was. Again, it helps me to understand the risks, but I'm still going to look at that child as just an individual, figure out their strengths and weaknesses, and they happen to have NF. But does that make sense?
Right. Okay. Thank you.
Thanks.
So my son is currently medicated for ADHD. If we were a candidate for one of these studies and wanted to participate, I assume he would have to be unmedicated for a period of time prior to the start of the study, and that terrifies me.
Nikki, do you remember what the final decision was on that? We had gone back and forth on this criteria for a while. I believe you can come in on, is that correct?
If you're on stimulants, I can yell too. If you're on stimulants already, you can participate in the cognitive training component and stay on your stimulant medication. But if you come to the study without taking any stimulant medications, then you would participate in both aspects of it.
Thank you.
Yeah, I was wondering, we live in a small community where
We don't have resources.
we don't have that many resources. But we wanted to know is how we can get involved in some of these trials and who we would contact.
Yeah, I think for a lot of individuals end up traveling, right? I mean, I know at our site we get people from kind of a pretty broad region because we're a center that has kind of a multidisciplinary clinic, but also is then involved in the DoD and the consortium and have the trials. So I think a lot of times, and in the STARS study, there were multiple sites across the United States and internationally, and we try to pair people up with the very closest site to them, which sometimes though is still quite a distance. So I think in terms of the, you try to locate the biggest center closest to you that is involved, and if that's the level you want to be involved in, I think you end up trying to coordinate with them on how to make that happen for you. But it is a challenge. We have a number of families kind of in the DC area that live way out in kind of way out in Virginia or in West Virginia, and they live in small communities. And it is a challenge whether you're talking about kind of school interventions and kind of, getting that going and having people understand NF and associated difficulties and how to handle that. And I don't know the solution except to try to utilize us in these centers, even if it's from a distance, to try to be helpful in educating people in your community, in helping you kind of educate people in your community and get some resources going. But it is a challenge if you live kind of not close to some of these metropolitan areas to get access to some of the things that we're talking about. But I think that what you can do if you're interested is get in touch with us, and if there's a principal investigator of a study, have us help you find a way to be in touch with them to kind of figure out how you can be part of these trials or part of these intervention studies. We're always happy to help if we can.
You can also join the NF registry, and you can get contacted through the registry for trials, and that's very important.
That's great, yes, thank you.
I was just going to add one thing, that sometimes different components of the study can be done close to home. So, I know when we have families that are coming from far away, we try and have them get their blood test done locally or other aspects of the testing done locally to try and work with you to make it as easy as possible. But even in Boston, we have families coming from New York or other locations that are far away, and we try and schedule it to our best ability around your schedule or school days off or work days off to try and make it happen. So it's a commitment on both sides to try and work with one another to make it feasible.
Thank you, Nikki.
So I think that's all the time we have. It's now time for a 15-minute break. We'll see you back here at 3:15. Thank you, Karen.